welcome back to the American Journal of Healthcare Strategy. I'm joined here today with Amy Wright. Amy, how are you doing today?
I'm great. How are you?
I'm doing fantastic. Can you tell me a little bit about yourself?
Yeah, so I'm Amy Wright. I am a nurse by background with a background in emergency medicine and nursing leadership. I currently am a director of clinical operations for Jefferson Health in the telehealth and urgent care realm.
And if I'm correct, you started off as a nurse.
I did. So my background is nursing, and that's really where my passion lies at this point. Starting out just as a brand new nurse at the bedside, it was really about being there for the patients, impacting their care, making sure that they had great outcomes during their visits, and that they had the consistent care, regardless of when you walked in or what department you walked into. That was really what I really wanted to see for every patient. And that has continued throughout my career, whether it's been from a nursing perspective or an administrative side. I really just wanted to see the best outcomes for our patients.
What inspired you to sort of transition from the clinical side to the administrative side?
It was all about how many patients we could reach. In my own little patient assignment in the emergency department, I knew that I could provide great care for the patients and the families, the 4 or 5 that I got to have at a time. But there was an entire emergency department of patients that needed to have that same care provided. And for me, stepping into a leadership role was a way that I could start coaching and mentoring and have some influence over other teams to make sure that they were after the same goals, which was those patients.
Right. There's many very skilled clinical staff, and usually they focus on one family at a time or one patient at a time. From an administrative point, I guess you could sort of have an impact in how many patients enter the clinic and coordinate their whole flow from entry to exit. So I think that's really fantastic. I think administrative
Yeah,
side.
and we still always want them to focus on one patient and one family at a time. But if we have the right complement of staff and we have the right support staff, we can make sure that every person that walks in is still getting that one patient at a time treatment.
And what inspired you to go to emergency medicine? Was this always the goal from the start, or did you sort of transition into it?
It absolutely was. So I was a little late to go to nursing school, and while I was trying to figure out exactly where I wanted to be, I did work as a 911 EMT. So emergency medicine was what I was comfortable with. I liked the idea of being able to be with patients very quickly, stabilizing them, figuring out what the issue was, what was going on with them, and then getting them to the definitive care that they needed. So many times it was about getting to a patient who was not feeling well, helping them feel better, and then sending them home. While in other cases it was, taking care of the patient and then sending them to the inpatient side of the hospital or sending them for additional treatment at another facility.
You mentioned you were a EMT before you went into nursing. Was
Yeah.
it a huge switch from going from the outdoors in an ambulance to sort of like an indoor setting for you to practice health?
Yeah. The emergency department was definitely more of a controlled situation than it was either in a patient's home or in the back of the ambulance. I can tell you that once I had my job in the emergency department, I kind of closed that chapter of my life of the pre hospital medicine piece and really focused on the in hospital care.
Since you were able to work both in the outdoor side and the indoor side, and you were able to see the patients from immediately after trauma to being treated in an emergency room to referring them to inpatient, what do you think as an industry that what can we do to sort of improve this patient care from the start to the beginning, from the start to the
That's a
end?
great question. That's a really great question. It's all about focusing on the patient. You are going to meet people in all kinds of different scenarios. And I had a colleague of mine say to me one day, like, it's our job to be the best part of somebody's worst day. And that really could not be closer to the truth, regardless of the situation, regardless of a life threatening situation versus a sprained ankle. This is an emergency for someone. It is life altering for them. It is a scary situation to be in. So, you, as the first person that they're coming in contact with, being calm, being able to walk them through what to expect, and being empathetic towards their situation, whether you perceive it to be an emergency or not, is the only way to meet the patient where they're at and be able to walk them through the rest of their journey.
And these skills you mentioned, being empathetic, being calm, being patient with these patients, is this something that you were able to learn while going through school, or is this something that you develop over time?
Yeah, I think, every interaction that you have with a patient, regardless of whether you're a student or, a licensed clinician, you have the opportunity to learn something from the patients that you're talking to. And falling back into the foundation of Maslow's hierarchy of needs, being able to just provide that foundational support for somebody when they come through the door. They are a human. They have basic needs. They want to be warm. They want to feel safe. They want to be given food and shelter and taken care of. And we strip them of so many of those foundational things and make them, take them out of their comfort zone, and that's going to increase their anxiety. So it's our job, to make sure that we're addressing those basic needs, to keep them calm, to make them feel like they have some control over the situation, and be able to keep them comfortable while we're waiting for those definitive diagnoses.
You mentioned Maslow's hierarchy of needs a few times in our previous conversation. Is this something that you feel every healthcare practice should focus on and sort of keep it in mind when meeting a patient?
So it was something that made sense for me. Patient experience is a huge piece of what we do. And I feel like many healthcare providers feel that patients are coming to them for help, and that patient experience sometimes is a whole lot of fluff. I had the opportunity to spend a couple of years as an ED patient experience coordinator, in an emergency department, and I really got to see how much of the control piece and those basic needs were driving the frustrations that patients were feeling. It was driving the conflict and the complaints that we were seeing. So I feel like as a clinician, or anybody that's interacting with patients, it's your job to figure out what clicks for you. If it's Maslow's that makes sense to your brain, and you can say, these are the things that I need to focus on in order to have a really smooth patient visit, then that works. If you want to go to, some tips and tricks from patient experience advisors within hospitals, it really is based on how your brain works and what makes the most sense. Ultimately, we have to meet the patients where they are, and we have to provide them care. And if we don't do that in such a way that makes them feel more comfortable and creates that trust between you and them, it's going to be a bumpy visit. And that's what we want to avoid.
What are some qualities of a provider do you commonly see that sort of aren't right when interacting with a patient who's definitely going through a tough time? I'm sure as a working in an emergency room. What are some of the
Yeah.
qualities that you notice?
I would never say that any of their qualities aren't right. I don't think that anybody comes to their job or to a patient's room thinking, I'm just going to be a total jerk to this person. I think that it's, you know, communication is always the number one thing that patients want. They want to understand the why, they want to understand what the next steps are. And for so many clinicians, that is so commonplace for us that it runs on repeat in our brain constantly, but we don't say it enough. So even if we feel like we're over communicating or we're saying the same thing over and over in our visits to our patients throughout the day, reminding ourselves that it's the first time in some cases that those patients are hearing it, and it's the words that they need to hear in order to be calm and to trust you and to comply with whatever your treatment plan is for them.
You have a background in telehealth, is that correct?
Yeah, telehealth is my new adventure, that I'm very excited about. Um, my my basis for moving into this role, it was COVID. Working in an emergency department or a hospital, during COVID, we saw the rise of telehealth. Visits that were being done by the primary care doctors, specialists that were, we called it zooming in at that point, or whatever platforms everybody was using, and it didn't feel right. And it wasn't that it didn't feel right for any other reason that our culture was not ready or hadn't been explained how this telehealth piece worked. It's no different than regular care, and I think that that's where the hang up was the perception and maybe not having enough information that these doctors were really skilled at how to assess people, whether or not they were putting a stethoscope on them or whether they had somebody that was assisting them in the room to put a stethoscope on them or help them with their exam. The care is the same. It's just done in a different way. And I think that that is the biggest barrier right now. And that's my goal for the position that I'm in right now. Having been a giant skeptic of telehealth and not knowing how much was out there, really jumping into it and seeing how my clinical brain and my skepticism can help maybe turn the tides of the feelings towards telehealth now.
What were your thoughts when you were skeptical of telehealth? What were some ideas that were going through your mind?
So, some of the thoughts were, are the doctors just afraid of the COVID virus? So they're afraid to go into the rooms and they're avoiding those types of patients. I had heard that all over the place. This doctor doesn't want to go in and see the patient, so they're just asking us to go into the room and set the patient up with their laptop or their iPad or whatever they were using. That it was a shortcut, that again the care wasn't the same, and that was one of the biggest misconceptions that I think everybody felt just with the speed of which it came out.
What do you see as the future of healthcare technology? Definitely telehealth will probably stick around. It's very convenient for patients who say live far away, are in an age where it's hard to move from place to place. What are some other ideas you have or you can see healthcare using in the future?
The future's so bright. The fact that we have the ability to take care and provide it in patients' homes, I think, is one of the biggest game changers. The changing tides of being able to provide that care at home, and then how do we then create an environment in the hospital where you're only there if you need to be there. I think that's going to be really different, and it's also going to probably increase the acuity of the patients that we see in the hospital. But with that being said, we'll have the ability to get a doc on and consult with another physician regarding the patient that's in front of them or the complex situation that a patient may be in. It's really whatever people dream it to be. Like if the bedside teams can open their minds and say, I think that we have a great chance of using telehealth to streamline our efficiencies and to make sure that we can get the patient's family on the line when we're seeing them, or get the top neurologist to see this patient to help us rule out stroke. It's only going to improve the access to outstanding care that our patients are getting, and then lead to better outcomes, more quality care, better safety of our patients. And I think that that's really where the priority is right now.
Yeah, that's very interesting. I agree with you. The future is very bright, especially with all the advancements. What are your thoughts on, I guess, AI in the whole healthcare picture? How do you see that fitting in?
Oh, so I think that in healthcare we are safe. There is such a human factor in healthcare that's never going to be replaced by AI. But I think what AI will be able to do for us in the future is make things more efficient. How can we take those tasks or things that are really time consuming for our clinicians that are taking them away from the bedside, introduce AI so that we can be more efficient and we can be more forward facing to the patient instead of stuck in administrative tasks.
I've been asking about how we as providers can sort of help patients, what we should focus on to improve their care. Is there anything that you wish patients should know about working in the healthcare side and being the ones trying to take care of them? Is there anything you wish that the patients should be aware of?
The tides have changed so much post COVID. And I think that people our patients even are less compassionate towards the teams that are doing the work, and are a little bit more short with them, get frustrated more easily. And that just creates this wall that goes up with our healthcare providers. And we don't want to be defensive with our patients. We want to make sure that we're very open with them and we're listening and we're taking in everything that they're saying so that we can provide them with the very best care and understand exactly what they're feeling, what they're thinking. When there's that shortness and frustration, it closes us off a little bit and it makes us not listen as much. And that's an us problem, but it's really driven by the patients, and kind of how they're presenting to us. So I would almost say to our providers, take the wall down. Every situation is like, your difficult situations are not going to happen all the time, and you can't use your past experiences with upset patients to dictate the future care that you're going to provide to another patient. So remembering that every patient is a new experience, is a new patient, is a new life that you have the opportunity to touch, and it's not just one life, it's all of the people that depend on them within their community, their friends, their families, the people that they take care of outside of that circle. So one person impacts way more, and we have the opportunity to make it a better experience for them.
Wow. Yeah. That's very amazing. I would like to say thank you for all the service you do for the community, for the patients, and your staff. It's very wonderful talking to you, and thank you for joining us.
Thank you for the opportunity. I really appreciate it.